Perfect. So once again, welcome to the masterclass in AI. There's a select group of people here who have exciting projects they're working on or exciting ideas. We aim for a mix of people who have significant experience with the state of the art or experience with the needs in the real world around artificial intelligence. And as I mentioned before, the second half of the workshop will be interactive. That will unfortunately not be available in recording. And the first half will be a lecture, a mini presentation on a very quick lay of the land in artificial intelligence and healthcare that will be recorded. So if you're watching this on recording, welcome. For everybody else, you just heard the same thing twice. So without further ado, I will start into a presentation about 30 minutes. That's a very quick overview of things that I think are important. And then we will break out into small groups where you can present your work. There will be a break. And there's going to be a second breakout session, and then we will reconvene for a large group discussions. With us here today is my colleague, Ariel Dora-Stern. She does not have a video on because she's actually on maternity leave, but we originally designed this course together, and so she is listening in, and we can all give her a warm welcome. So,
quick question.
Yes.
Are you going to be able to provide us with the slides later?
Yeah, that shouldn't be a problem.
Thanks.
And thank you for saying that. That's exactly the right approach. Given that we're a small group by design, where I looked at every one of your applications and tried to get a group together of people that hopefully are a good fit, I would like this to be as interactive as possible. So please just jump in whenever, either raise your hand or just talk over me if you have any questions. This is not a me talking at you situation. What I would like to do is, in these 30 or so minutes, get a quick lay of the land. So sort of see what AI is all about, look at some case studies, have a brief consideration of ethical aspects and how that carries over into regulatory news. Then we go, as I mentioned, to breakout groups and have a discussion in the end. So to get into that, there's a lot of excitement around artificial intelligence in healthcare, partially because there is significant money flowing into the space, as I'm sure many of you are aware. I think it's a very exciting time to be in this space. This is a paper that my colleague Ariel Stern co-authored. There's a citation on the right. I can highly recommend it because I think especially this table gives you a good overview of different applications. So if you're just coming at it and figuring out what are potential applications of AI algorithms in healthcare, I would highly recommend this as a concise summary of different ideas. And I will try to put some life into this with more detailed examples, but just to give you an idea, anything from documentation to orders, data entry, scheduling, triaging. So administrative work are fields. There's a lot in imaging. I think a lot of people tend to think that AI in healthcare is just imaging. I personally believe that some of the more exciting applications are actually outside of imaging. There's just sort of an overcrowded field, but some of the more exciting or more impressive stuff happens in imaging. There's diagnostics, there's phenotyping, more data sources, there's surgical robots, there's more and more personalized medicine. So the deep combination of biotech with algorithms, there's behavioral stuff, and so on. So last but not least, I should mention digital therapeutics, because here in Germany, we launched the DiGA fast track about a year ago with about 24 smartphone apps now reimbursable through public health insurance companies and prescribable by doctors, which is very exciting. And of course, also enables use of AI with patients. So why are we talking about AI? The first thing that for me, and maybe I should introduce myself briefly, I am a data scientist. I studied econ and philosophy in undergrad and then data science in grad, worked for health insurance companies in claims management, and had the privilege over the last years to get a pretty broad scope of AI and data related ideas in healthcare. And what that also tells you is I'm not a physician. I did never study medicine or even biotech. And so coming into this, I was fairly shocked to see this. What you see here is some people may have seen it, is a table detailing what's called inter-observer variability. in diagnostics. People who are familiar with AI might recognize that this is a confusion table for a classifier, except that the classifier is one physician versus a consensus of many physicians. So the ground truth labels that we have on the left are the diagnosis that a panel of physicians gives. And on the x-axis, we have the predictor. So one individual physician in a real world diagnosis example, what they diagnose the patient as. The diagnosis here is biopsies of prostate cancer. So somebody had we think a patient has prostate cancer. We take a piece of tissue from that prostate, a small surgery. We cut that piece of tissue into very fine layers, we put it under a microscope, and we look at these images to say how bad is the cancer. And basically from left to right, cancer gets more and more severe. And somewhere on that scale is a cutoff from, we'll just wait this one out to, okay, we need to take your prostate out with fairly severe consequences for the patient, because it often means incontinence and impotence and all kinds of things that you don't really want to suffer through if you don't absolutely have to. So if you land on the far left side on the 3+3 Gleason grade, as it's called, you're probably fine to wait a little bit. The further on the right you land, the more likely it is that you will have your prostate removed. So this is not, a small detail, is pretty relevant for the patients who suffer through this. And so the question that we now want to look at is, how well does one physician, and this is in a major German university hospital, this is state-of-the-art diagnostics, how well do they fit the consensus of a large and experienced panel of doctors when they really look at it? And what we observe is that they are very bad at hitting this consensus, where almost a third of patients where the consensus says this is benign and we might not need to operate here, might not need to do surgery here, will receive surgery unnecessarily. And only 2/3 of diagnoses are exactly correct, which is better than educated guessing, but also not so much better than educated guessing. So this shouldn't maybe be surprising, because we have humans staring through a microscope all day, morning to evening, or often during the night, and doing image recognition, right? With their eyes, they're looking at pieces of tissue, they're looking at images, and they're comparing in their head what they're seeing to something they learned in a textbook. And we all, like this, they're not bad people. It's just difficult to do this job in a time-constrained environment. Stress around you, the phone is ringing, and you might not always see everything. So it's not that doctors are bad, it's that maybe looking at small images of tissue all day is not what humans are actually all that good at. So maybe it isn't surprising that inter-observer variability, as it's called, is so bad. This holds through a lot of fields of medicine. It's particularly bad in pathology, to be fair. So this is a cherry-picked example, but as a general take-home message, I think it's true for a lot of fields. And the first question I want to lead with is, if this were the result of an AI system where the predictor is not one individual physician, but instead an AI algorithm, do we think we would deem this appropriate performance for such a system? And I think the first take-home message is, it should be relatively straightforward to beat the individual physician. It shouldn't be surprising that it's possible to do this. And there is real world benefits to be gotten from using better systems here. In pathology, it's also particularly hard, but that may be a second story. The second point that I want to emphasize, and I'm just giving you 4 very different ideas to go quickly through these case studies, is, okay, so now we can fairly obviously do better in diagnostics. Why don't we have AI-based diagnostics everywhere? And one main point that people who know AI and know medicine, in my experience, continuously underestimate is the importance of reimbursement systems. So healthcare is an industry like any other industry, and healthcare is shaped by how revenue models work. That's sort of an uncomfortable truth, but I think it's just a reality of how the world works. And maybe it shouldn't be so surprising, because everybody wants to earn money in some way. So again, shouldn't be surprising, but a lot of people tend to forget this really crucial part where just having better diagnostics doesn't necessarily mean anybody's interested in your product. One way that we can learn from this is there are business models that are very cleverly designed in addition to AI-based models that then actually get some amount of market penetration. This is an example I wanted to share with you. A company called Zebra AI that has a trial in the UK where they use their system to diagnose these hairline fractures in the spine. And these come often from osteoporosis. And basically you can see them in CT scans of the thorax, but typically they will not create symptoms early in life. They will become a problem later in life because then these very small fractures in your spine become back problems, right? The neat thing that they discovered is we take a lot of a lot of X-ray images of the spine for vastly other reasons, including for lung problems, where you just take an X-ray of the spine. And so in these images, you could see hairline fractures in the spine because it's there. But because it wasn't the idea of the picture of the image, the doctor in the first place didn't necessarily look for these fractures. Now, from a hospital perspective, this is hugely interesting because they're sitting on a trove of images that include the spine that weren't necessarily used for this, that you can now pipe through a classifier and say, these are patients that may have these hairline fractures. We can now send them a letter and say, hey, we found this secondary diagnosis in your data. We would advise you come in to have it checked out. These people make a second appointment and they might go for surgery. And that's interesting because you have these elective surgeries that are well reimbursed. You can schedule them if you have time in the surgery theater. And sort of the patient perceives it as added value. The hospital takes care of people's safety. So if we believe that this is actually a good thing to diagnose early, this is a tremendous innovation where we can just do extra diagnostics on data we have anyway using AI, where normally physicians' time would be too costly to look at all of these scans. Using an algorithm we can. And this can really advance the quality of care. There's a risk that I just want to flag here, which is doing surgery on people's spines isn't something that is free. You might end up doing surgery on people that may never have gotten back problems because you can just diagnose it earlier. If that is the case, we have built a system that creates a lot more revenue for hospitals and does a lot more elective surgeries that maybe actually decreases quality of life. So there's a certain risk here, and we should be pretty sure as a society that we actually want to operate these people. I'll pause here briefly and just check if there's any questions or any remarks. Cool, then I will press on. Now, again, completely switching gears. I mentioned that personally, I think some of the most exciting applications of AI in healthcare are actually outside of diagnostics, because diagnostics is difficult. It's sort of hairy. It has all these second order effects, as I just mentioned. And there's, I think, a lot of low-hanging fruit in the administrative side of care delivery. So how do you actually get to delivering the care to the patient who needs it? This is one example, a company in the US that primarily does scheduling for infusion centers. So this is oncology typically, so cancer care. People need to get regular infusions of chemotherapy. They sit in a chair for an hour or two while they get the infusion. There's a nurse there watching them, and then they go home again. And in these situations, you have just a messy sort of industry 4.0 type operations problem, which is sometimes it takes longer, if there's complications. There's no shows, people just don't come. People are complicated, and that just sort of throws off your schedule for the day. And so these are things you can predict if you have the right data, and you have confidence intervals over patient behavior in these situations. And using these confidence intervals and using these predictions, we can do much better in blocking our schedule over the course of a day. So basically what you see here as a visualization is every row is a chair in their example, and then on the x-axis we have time. And so basically they're saying a normal schedule would look sort of like the gray thing that you might see in the background, where there is peak, and then sort of a lot of chairs are actually empty. And they're saying by blocking usage of these chairs, we can do with fewer chairs or serve more patients. Really not super high tech, but makes a huge difference in how people can get access to these services. And then, of course, some of this might not even need AI in the narrower sense of the word. Some of this might just even be you can cancel and reschedule an appointment by using a website, as opposed to having to call and then somebody doesn't pick up and then you become a no-show. So there's the operation side of things that really doesn't really need AI, and then there's a optimization piece that can benefit from additional data that we have. And then the final example that I wanted to show goes back to my own personal experience. The company on the right is where I used to work. But basically in reimbursement, we have this fundamental problem that we have providers that render services, hospitals, doctors, pharmacies, and we have patients that typically in Germany don't really see the cost they create. And then we have payers, so insurance organizations. And because the consumer of the service doesn't really see the cost, there's all kinds of funny incentives as to how we bill for clinical services. And so the company on the left is a cool example from Germany that does what they call right coding. So they look at the clinical data in a hospital, the electronic medical records data, and automatically create coding from this medical documentation. So these are the billing codes that you can use to get money from an insurance company. They use ML for this and expert systems, and basically promise to get more efficient coding of medical stays in hospitals. For their specific example, I actually believe that they do very good work, and I think there's nothing fishy about it, but there's always a risk of upcoding, as it's called, where you find that adding a small diagnostic detail to a case gets you a lot more money for the same hospital stay. And so there are incentives in a system where hospitals, for example, systematically do this to get more revenue. And as a response on the health insurance side, we have companies that just do the opposite of getting an insurance claim and saying how likely is it that this thing was upcoded, was inflated. May this actually have been a simpler case than we expected. And then call the hospital and say, okay, hey, did you really need to do this procedure, or was it maybe revenue driven, and can we just deflate the claim again, take this extra volume out? So there again, you have specialized machine learning where you learn how likely it is that you can deflate a claim and save money on it. Super, super niche topic, but in Germany alone, there is a couple hundred, probably about €1 billion in savings achieved through this. So revenue that is taken off of inflated claims that is taken down through ML and expert systems like this. And so this is a great example, I think, of, as a nerd, everybody's really happy, but in reality, it's just kind of a weird system that we have ML on the one side to inflate claims, and then ML on the other side to deflate claims again. And overall, it's just sort of frictional cost of having a healthcare reimbursement system. But again, in the case of Tiplu, helping doctors get from EMR data to efficient coding is a huge saving, and helps people document better, essentially, and helps create these linkages between the coding element that you see and the actual clinical data in the EMR, so you can basically tie back your coding to actual lab data or medical procedures. Cool. Then I will just briefly mention that, of course, ethical considerations are important here. The main point that I always want to point out is, machine learning in particular is only ever as good as the data that goes in. There's a lot of talk about bad data quality. I'm sure you've heard that, but in particular, representativeness is really core, because if you train an ML algorithm on data that is not representative of the patient population you want to use it on, then you shouldn't be surprised if the algorithm doesn't work in reality. So there must be the patient that you want to use an algorithm on needs to be included in your training data. This is something that I think in the US has made the news a lot recently. And so I think people are awakening to this issue. One great example is that one of the best data pools in the US for clinical data is the Veterans Association hospitals. They have very good and very homogeneous hospital data. The only problem is it's a Veterans Association, so 96% of patients are male. It's the Army's veterans, and so using that data to train any sort of algorithm tends to produce terrible results when used on female patients, and that of course is not a desirable outcome when we produce algorithms to actually be used in production. In the same spirit, I think there's a lot of regulatory approaches to reining in this problem, to better regulating market access. This report from earlier this year is an interesting read. I personally think they are focusing a little bit too much on future problems and not enough on problems we have today, but maybe we keep that for the discussion later. And with that, I'm already at the point of giving you a quick update of sort of what happened in the last 4 years in AI regulation in Germany and Europe. So first of all, I mentioned we have this trove of billing data in Germany that is very homogeneous and they give you longitudinal access to a whole patient history. They are born often in a hospital and you get a DRG and you have a good idea of what happens when they were born, and then they have a whole life, and then they die often in a hospital, and that also gives you a DRG. And in between that, there's a lot of diagnosis codes and procedure codes and medication codes. And all of that data is available through the public health insurance companies. Historically, it's not been super available for research, and we are going to change that through the Forschungsdatenzentrum, the research data center, which was renovated in the last legislative period and is expected to go live, I think, early next year for research access, where I hope we will have access to the full data available to the public health insurance system longitudinally in a career-based system. And I hope that a lot of very exciting research will come out of this data access. Yes.
What falls under research here?
Research in the relatively narrow definition of research. So in particular, in an original draft of the law that I saw, industrial research was included in that law. In the final law that passed Parliament, this is, I think, due to political majorities, industrial research is not included in the list of allowable uses of this data set. Now, that being said, it's not uncommon for industrial research to happen in collaboration with research centers at universities in the medical sphere. So it's not uncommon that you have a research project at a university that is partially funded by an industrial organization and where the results of that research may be shared with industry partners. The industry partner isn't allowed to see the raw data, but they're certainly allowed to utilize the results of academic research for their work. So I think that would be the workaround of that issue that I would see for now. And I think that's generally true for a lot of the new data sets that we are making available, that it's very difficult to get access to them for commercial purposes, except if you go through public academic research institutions. But it's a start, and I personally hope that this will change in the years to come. But looking back at the last 4 years, it's fairly amazing how much data we've made available. And I think it was a small price to pay that industry wouldn't get access directly in the beginning. The second thing I want to highlight is the Center for Cancer Data, which was also revamped. This has very detailed clinical data for cancer patients, also updated. One thing that actually something I added at the very bottom. This is very much going to the future, but Germany is investing in genomic data. So this is genetic sequencing for cancer patients and rare diseases, where Germany will invest a lot over the next 5 years. And the data is also collected in the public data set at BfArM. And this will also be made available to research, similarly to how the research data center works. One thing that I want to briefly mention, in case you are doing research, I personally found this very confusing. There is research grants, of course. Germany supports research into public health. There is the Bundesministerium für Gesundheit, the Ministry of Health that I work at through HIH, that does applications. So they will support work that directly impacts patients. And then there's the BMBF, Bildung und Forschung, so this is the Ministry of Education. They support pure research. So this is where you would go for stuff that doesn't directly impact patients. The Venn diagram, as you can see, isn't always super, there's an intersection. It's not always disjoint. And I find that a lot of interesting work happens in that intersection, which can be tricky because then both ministries say that they're not really responsible for it. So the reason I'm saying this is if you do research in this field, it might be helpful in your proposals to very clearly fall on one of these two sides and thereby qualify for support from either one of the ministries. Almost finally, somebody already, I think Diony, you already mentioned MDR, medical device regulation. This is an ongoing process that is more and more, becoming applicable to new products. It's a large body of legislation and rules. I can't cover all of it here, but just to be aware, there's a lot of changing rules around medical devices. And I can't cover all of it, but many of my colleagues at HIH have. So I would recommend looking at the YouTube channel that we have for recordings of previous sessions where we went into some detail on many of these things. Cool. So before we break up into smaller groups, and I will tell you more about how that works, I want to have a short view into the future as I would like to see it, coming back to the ethical question of representative data, where I think on a very high level in Europe, we have the situation that our high standards for data privacy make it harder for companies, for industry to get access to representative data because it's just harder to get data to begin with. And so people tend to work with smaller study cohorts that are by definition not representative. That is sort of suboptimal, but maybe defensible. But it brings us to a situation where I think it's unrealistic to assume that companies are able to get truly representative test data for their medical devices. So the way that a lot of AI works, and some of you will be familiar with this, is you have training data and you learn to find patches. This is a pathology example. You learn to find cancer in these images. And then you have a test set that you've never used for training. You predict cancer in these test images. And if your algorithm does as well as a baseline, for example, a human pathologist, then you say, okay, this seems to work because it's finding patterns that is never seen during training. This test data, therefore, is really crucial because that needs to be representative of the people who want to use it on. And because it is difficult to get this representative data in the European Union, I think there would be a case to be made for governmental support in collecting such data. And this is actually something that we as ML people aren't fully unaware of. That is exactly how platforms like Kaggle work, where you have training data that people sort of get and train on, and then there's a test set of data that is kept secret, which, for example, could be done by the European Union or by the World Health Organization, that is used to certify algorithms and show how well they've worked in practice. The added benefit of this, and again, these are sort of my ideas, these are concepts people are talking about. This is not yet the state of reality. But the added benefit of this would be that in situations where we have data drift, where the population of patients changes over time, this would allow us to recertify algorithms. One last example that I want to give for that is Google is walking around with very impressive results of a dermatology classifier that basically allows you to take pictures of skin, and then they test for a couple dozen different skin diagnoses, including skin cancer, but all kinds of other things. That's a great example because you would train on historical data, say in Germany, images of the last 10 years of patients, and you learn patterns. And then we have these macro trends, like an influx of people into Germany over the last years that maybe are a little browner than people used to be in the last 10 years. And so we want to know if the classifier that we've trained on people in the last 10 years will work as well on the patients in the next 10 years. And this is a fundamental problem in these data drift situations, that we would actually like to recertify products for the representative patient as that population is changing. And so I think this is an additional argument for collecting such test sets and then reusing them over time to make sure that products still work as well as they used to when they were first admitted to the market. And that concludes my little presentation. If there's any questions immediately, I'll be happy to take them. Otherwise, I would explain how we were going to go into workshops.
Hey, Lars, this is Gurmeet from Switzerland. I think for my purpose, if you wouldn't mind reiterating what is the objectives of this workshop, because it's unclear or I might have missed it. What's the purpose?
I'm sorry. Thank you for the question. The purpose of this workshop is to connect people that have ideas or research with each other and to then get into a fruitful discussion. So my little presentation was supposed to give you a few ideas of what else might be out there. And then you all got a little pre-workshop assignment to prepare these three things in the top right, which hopefully will facilitate a getting to know each other round, where you meet a small subgroup of people. And then in these groups, you will share what you're working on, what you're excited about, and discuss that. And then we will come back into the plenary session and do the same thing again with a different group. And then finally, we will present the ideas discussed and enter into a broader discussion in a big group about what might work, what might not work. We can talk about ideas for reimbursement. We can talk about the state of the art of AI as it applies to some of these ideas, and go into a hopefully fruitful discussion. And my hope is that maybe out of all the people here, some people stay in contact after this and build artificial intelligence powered medical devices that help patients, or scheduling, or documentation, or any of that stuff. Did that answer your question?
It does. It's a networking event. I have a question and a concern. I think if you're going to be sharing our ideas, it is a competitive space. How do you see that being managed? I understand the value of networking and support, but the reality is it's a competitive space.
So definitely don't feel obliged to share anything that you believe is an industry secret. Nobody has to share anything, and we will not share your answers of the applications either, if that's your concern. I would say people tend to overestimate the value of ideas and underestimate the difficulty of implementing them. So I think I personally wouldn't be too concerned, but by all means, don't share anything you're not comfortable with sharing.
Okay, thanks.
And I mean, people who have one idea that's so good that they can't share it, maybe have a secondary idea that they're more comfortable sharing. So I already briefly went into this. What I will do next is assign you into breakout groups. There will be hopefully 4 people per group. And you have prepared these 6 sentences that are a helper to quickly pitch what you're working on, what you're interested in, and where you're interested in learning more. I would invite you to quickly go through that. If you need help, you can go in alphabetical order by surname, starting with A and ending at Z. I will mention that you will most likely be alone in those groups. So you will need to self-organize because it's only me moderating and there'll be several groups. After about 15 minutes, I will bring you back into this room. We will quickly reconvene and have a 5-minute bio break. Then I would ask you to be back on time, and we'll do the same thing again. And now that we've practiced these pitches, the idea is that in your groups, you select one idea per group that you think is most interesting or most likely to spark a conversation. So this might be somebody who has a concrete ask and needs help. This might be somebody who has a concrete problem to solve, or something that's somehow discussion worthy. And then we'll come back into the session and hopefully have a fun discussion to close things out. Any other questions?
Sorry, I did not get exactly. Will we be paired first with a group of 4 people, and then after the break with a different group of 4 people? Yes,
that's correct.
Okay. And in both cases, we should also decide for something that one of us will present.
That's only the second group. In the first group, it's the first getting to know each other. It's a warm-up. And then in the second group is where you choose one person from the group to present their idea to the plenary session.
Okay, good. Thank you.
Are there any more questions?